Bismillahirrahmanirrahim. We will discuss today the perianal fistula and perianal abscess. Perianal fistula is also called fistula in. It is abnormal communication between anal canal and rectum with perianal skin. Pathology is there is persistent infection of the anal glands. It leads to Ischiorectal abscess formation, which ruptures one end opening into the anal canal or rectum and the other end opening onto the skin. It persists because of infection and absence of rest to the area. Multiple perianal fistulas always consider some chronic illness such as tuberculosis, Crohn's disease, ulcerative colitis, or colloid carcinoma of rectum. Classification. One is the standard classification we have been using since long. The subcutaneous, it may be submucous, it may be low anal, high anal, or the pelvirectal type. Second is pars classification. It says that it may be intersphincteric fistula, transsphincteric fistula, or the supralevator fistula. Clinical features. There is persistent seropurulent discharge. There is history of perianal abscess. External opening may be single or multiple with pouting granulation tissue. What is Goodall's rule? A fistula with an external opening in the anterior half of anus and within 3.75 cm tends to be of direct type, and the one in the posterior half indirect type or curved fistula. In the fistulae which are in the anterior half, they have a straight course. The external opening is at the same level as the internal opening. But the fistulae which are in the posterior half or in the anterior half, which are more than 3.75 cm from anal verge, they have a curved path. The external opening is not at the same level as the internal opening. They follow a curved path. The external opening may be at any place, but the internal opening usually is in the midline position at 6 o'clock position. Diagnosis. The external opening of the fistula is found around the anal verge with pouting granulation tissue and minimal discharge of pus. Internal opening may be felt as an indurated area on digital rectal examination and sometimes can be seen on proctoscopy or sigmoidoscopy. Sometimes the entire tract can be felt as an indurated cord-like structure. The investigations which can help in the diagnosis are endorectal ultrasonography and MRI. MRI is advised for all complex or recurrent fistulas. Treatment. One is the fistulotomy. A probe is passed from the external opening into the internal opening and the tract is laid open. It is allowed to heal by secondary intention. It is relatively easy procedure. There are least chances of recurrence and there is minimal risk of incontinence. And we use it for low anal fistulas mainly. Fistulectomy. In this, the whole of the tract is excised. It is done for chronic fistulae of low variety. Satin insertion. This is used for high anal fistulae, the fistulae which are intersphincteric or transsphincteric type. A non-absorbable suture is passed through the tract and both ends are tied. And the patient is asked to come on weekly basis as an outpatient. And at each visit, we tighten this settle. And this process continued for about 6 weeks. And in most of the cases, in 6 weeks, the tract cuts through it and it heals. The idea behind this is that the satin acts as a wick drain for continuous drainage of the abscesses associated with the fistula. And the tract is gradually shortened and ultimately disappears. And this is how it helps in healing. Fistulectomy with colostomy. This is done for complex fistulae of recurrent variety with multiple tracts, especially when associated with some chronic disease such as tuberculosis or Crohn's disease, with partial or complete excision of the tract with or without satin insertion. Local and systemic treatment is started simultaneously. Some degree of incontinence is always expected because of sphincter damage later on when the colostomy is reversed. It is the treatment for complex perianal fistulae, complex and complicated perianal fistulae. Perianal abscess. The perianal abscess starts as an infection of perianal glands. The causative organisms usually are E. coli, Staphylococcus aureus, Streptococcus, bacteroids, and some other types of bacteria. Blood-borne infection can occur, especially in diabetic patients. Types. First is the perianal abscess. It is due to infection of the anal glands in perianal region. Sometimes it may be the infection of the external thrombosed pile, or it may start as a boil which spreads in immunocompromised patients or in patients who are prone to infection, such as the diabetic ones, the patients on steroids. The boil, starting as a boil, it can spread and lead to abscess formation. Signs and symptoms are there is a painful swelling in the perianal region and it causes persistent severe throbbing pain in perianal region. Treatment is incision and drainage under anesthesia and antibiotics. We start antibiotics, we send the pus for culture and sensitivity, and when the report comes, we change the antibiotics according to culture and sensitivity report. Bismillahirrahmanirrahim. We will discuss today the perianal fistula and perianal abscess. Ischiorectal abscess. This is collection of pus in the ischiorectal fossa. It is bounded above by the levator ani and below by the pad of fat in ischiorectal fossa. It occurs as a spread of the perianal abscess, or sometimes it can be blood-borne infection in the people who are more prone to infection, such as the diabetic patients, the immunocompromised, patients on steroids, patients with malignancy, and sometimes the AIDS patients as well. Clinical features. There is severe throbbing pain in ischiorectal fossa. There is an indurated tender mass felt in the perianal region. It is common in diabetic patients. Patients usually have high grade fever with chills and dry gills. Digital rectal examination, a painful boggy swelling may be felt on one side of the anal canal or rectum. Treatment under anesthesia, a cruciate incision is made, the pus is drained, all loculi are broken, the cavity is thoroughly washed with normal saline or pyodine solution, and then it is packed with a sterile gauze. Patients started antibiotics. Empirically, we will start antibiotics immediately, and we will send the pus for culture and sensitivity. When the report comes, then we will change the antibiotics according to culture and sensitivity report. Pelvirectal abscess. Actually, it is a pelvic abscess which is drained through the rectum. Common causes are pelvic peritonitis, perforated appendicitis, or septic abortions. Ultrasonography and CT are useful investigations to diagnose. The pus is drained per rectum. After rectal drainage of the abscess under GA, broad spectrum antibiotics are started empirically, which are changed when the culture and sensitivity report comes.